I'll start from the beginning by saying that this category of device has been something that I've been interested in and have followed for a number of years. And as I was telling you before, I think that historically the quality of EEG signal that was really possible with these types of devices was pretty limited. So I do think that this device, on a positive note, has a real potential to begin to deliver on the promise of a portable and disposable EEG system that's low cost and could be applied even by a non-technician, which is a real benefit. I think that really is the sweet spot for this type of a product, and I would envision it being used in places that currently really have very limited EEG access, if any. So that would be places like community hospitals, which typically don't have a technician on staff either for the nighttime or at all. And so they don't have the opportunity to do EEG studies even when they're clinically warranted. And then emergency departments would be another big value. So I think the ease of use, the fact that an individual can learn how to apply this relatively quickly without the need for using a technician, and then the quality of the signal, from what I've experienced so far, seems to be quite high. And so that would be of value obviously to the neurologists who are interpreting it. Well, I'm not sure what my expectations were. As I said, I've followed this space for like 2 decades basically, but I've been impressed. I'd say that there's 2 elements. So as I was just mentioning, the ease of setting it up. So it definitely has been designed with the notion that a non-technician would be able to do this. And then, at least in my experience thus far, I think that the quality of the signal is good. I don't know that it will necessarily replace, a full, telemetry grade rig, but at the beginning, that's not really going to be the intent, right? I think the intent is going to be to get a medical grade signal that would be appropriate for, say, a spot EEG in an ICU setting or in an emergency department. And from that perspective, I think the signal quality appears to be very, very good. In terms of improvements, I think that one thing would be to consider other types of electrodes. So, the current system has a fairly comprehensive set, but there is some areas of the brain that it may not adequately cover depending on what the clinical question is. I think that we need to think about designing the rig for a variety of head sizes, and I know you've already thought about that, but many times the pediatric indications will be important for this, and I know that you're already working on that. I think that on the interpretation side, so far I've been impressed with the size of the amplifier and the relative efficiency in getting a signal up and running. But if you think about the use cases that I mentioned so far, I think that many of those hospitals, if they don't have an EEG technician, they're also probably not likely to have a neurologist who can review at a moment's notice. So some type of cloud-based system that would allow for remote monitoring of the EEG signal, or incorporating some type of machine learning algorithm that would allow for even an ICU physician or an emergency room physician to quickly determine if a seizure was happening or not. I think that it's a very attractive device product for what I would say there's a situation where there's no standard of care currently. I told you this previously. So, in community hospitals, they typically don't have EEG resources. And yet the question of whether a person is having a subclinical seizure or not comes up quite frequently. So that could either be in an emergency room setting, someone comes in from the field that has impaired consciousness, or in the ICU setting, right? So there's been, in the past 10 years, an increased recognition of subclinical seizures happening in intensive care units. And yet in these community hospitals, they just don't have the resources to provide that type of testing. So I think this is a tremendous benefit. I mean, it essentially allows nurses at bedside to be trained relatively quickly to apply a basic headset and then collect the signal relatively quickly, and then hopefully have someone available for remote interpretation. Now, after that, there's a variety of other benefits that you could imagine. So longer recording EEG, you could envision this being very useful for your traditional long-term monitoring settings. Ambulatory monitoring is becoming a lot more frequent, for just diagnostic purposes, and so if this was able to be taken home and worn, I think that would also be a pretty big value. Sometimes there are patients on the floor, right? So we get a variety of consult questions. It can either be ICU setting. I think that's probably the most common. So mental status change is the medical buzzword, and often the question of whether a person is having a seizure or not comes up. And currently, if there's no EEG resources available, it's basically a clinical question. And at a specialty care center like where I work, we see patients who have been in another hospital for a while, and they eventually get transferred to us, and we suspect that they were having seizures that were not diagnosed. So I think that this would be, it's not necessarily the fault of that hospital. I mean, there's only limited resources, but this would enable them to, at a relatively low cost, gain a test that they don't currently have access to. I don't know that it's going to be the very first use case, but I certainly think that with some, evolution, it could be a candidate for an ambulatory approach. So, the current standard of care for outpatient diagnosis is a routine EEG study, which is done in a lab. Typically, it lasts 30 minutes, but the utility of a routine EEG test that's negative is relatively limited, right? And so it's pretty common that we would prefer to get a longer period of recording, perhaps even catching some of the patient's events in their home environment. And historically, ambulatory EEG rigs were very artifact prone, so it made it difficult to trust the signal. But I think that with this cap, because it's so easy to apply, and if there was some durability in terms of being able to provide longer monitoring, I think that the ambulatory market would be very, very interesting. From an outpatient perspective, I'd say my answer would be very similar. Telemedicine is interesting because when it comes to neurology, I kind of prefer to see the patient at least once, and then I can do my follow-up visits via telemedicine just because it's so convenient for the patient. But I really prefer a face-to-face visit. If there was a patient who lived remotely and that was a diagnostic dilemma, then I think that an ambulatory approach, as I just described, would still apply, whether that person was seen first in person or in telemedicine. That's a good question. So, I work at a specialized center, and we have resources that some of these hospitals do not. That being said, we do have, nighttime tech coverage, and if this product could make that more efficient, meaning that we could do spot EEGs more quickly with the assistance of a nurse, and then I could review it remotely or even the next morning as we do currently, then that would be of value. But again, I will note that, our hospital is unique, right? Most hospitals don't have the type of resources that we have. And then I think, again, kind of the next phase with more evolution, if this system was able to provide more long-term monitoring, I do think we could envision a day when this replaced some of our current long-term monitoring equipment. And I think that the ambulatory market would be interesting, even at a specialized center like ours. There certainly could be. I think it's maybe a little premature to talk about that. So, research in EEG and in settings outside of epilepsy is really growing. Most of that currently happens, again, in a lab setting, so a very controlled environment. And I'll reiterate that it's very difficult to detect brain signals, right? So whenever we run an EEG, the vast majority of what we see is not even coming from the brain. And so I guess one hesitation I would have is that I would think from a research perspective we would need to do some validation studies to show that the signal that we're getting from the cap is non-inferior or superior to what the traditional research rigs are showing. But if it does, then yeah, this would have the same benefits in terms of easy to apply, very efficient. And so I could definitely see it being used for research purposes. Overall, I see EEG use increasing. I think that if you segment out the different types of EEG testing, you may see different shifts. So I would break it down into a few categories. So if you look at routine EEGs, which are typically kind of the first test that an outpatient gets, that probably is plateau, maybe increasing a little bit. Long-term monitoring may be increasing a little bit, but that's been a pretty well-established treatment or diagnostic and treatment, I guess, test for a long time. I think the ambulatory market is really what's accelerating. Right? So historically, as I said before, that was a challenging space because I think many neurologists felt that the quality of the study wasn't adequate. But now, because of products like this, I think that the ambulatory market is getting a lot bigger, and there's a need for it. So a lot of these patients who previously got EEGs that were normal, but we still hadn't answered the question, they could really benefit from an ambulatory study lasting, say, 2 to 3 days. And so I think that market is increasing. I mean, the ambulatory answer. So I think that market directly addresses, or is directly addressed by that type of a product. And I do think that people will gravitate towards using that, particularly if the reimbursement element is also a part of that, right?
Absolutely.
So, yeah. I think that innovation in medicine is a lot slower than people realize or like to acknowledge. So over 5 years, I don't know that I see a tremendous shift, but I will say a couple of things. Mm-hmm. So first of all, and I already mentioned this, as the quality of the recording just gets incrementally better, you'll see a moment in which there's kind of a tipping of the scales, and people will become less concerned about using a portable rig or an ambulatory headset. And so that doesn't happen overnight. It takes probably decades for that technology to come to fruition and for people to get comfortable with it. But I do think that's happening. I think that's happening. That's why we're having this conversation. So that's one thing. I already mentioned, I think that ambulatory is going to increase in terms of its use. I believe that if you believe the trend in machine learning is going to continue, that automated algorithms for evaluating this EEG content will become more machine-based. I think that will happen. But similarly, that isn't going to happen overnight. That's going to be a very slow process. And then I guess the final thing I would say is that I think EEG is increasingly going to be relevant to other conditions outside of epilepsy. So, everybody wants to find an objective biomarker for things like autism and schizophrenia and concussion and traumatic brain injury. And I think that we're still in the research phase of that. It's not ready for clinical prime time, that's my opinion. But certainly we're headed in that direction. So it would not surprise me in 5 years that EEG was routinely used to help diagnose those conditions as well. Well, so I've already mentioned some of them. So I think that if you think about, say, long-term monitoring, that the product would be very attractive for that. But we would need to think about, getting an indication for longer-term use and making some changes with the gel and the electrodes so that they could stay on the head longer. I think that the ambulatory care market will require some tweaking to the product as it currently exists, although it may not be a very big change in order to have the patients wear it at home. Software looks good. It's very simple to set up, which is good. It doesn't yet have a lot of robust tools in terms of like doing automated mapping or power spectral analysis. So that's a feature that could be considered. As I mentioned before, I think that using some type of machine learning algorithm to do a screening test on a study would be of great value, particularly if you're talking about, say, a community hospital that may not have an on-site neurologist to review it. That would be potentially of benefit. We've talked previously about using a cloud-based system to store the EEGs so that they could be readily accessible remotely. I think that would be a tremendous value. That may be the biggest value because You may have someone sitting in San Francisco able to read an EEG from 6 hours away in Northern California, and that's a tremendous service that doesn't exist today. Probably simple inertia is the biggest one, just that physicians tend to be set in what they do, and so it takes time for doctors to assimilate new data and change their practices. That's probably the biggest one. I think that a certain level of validated evidence to make the physicians comfortable with the quality of your data will be important. I think a comparison with the gold standard EEG setup, and you could envision some type of pilot validation study with a fixed number of patients, and just thinking off the top of my head here, some of them, or they all get a traditional rig with a technician applied set of electrodes. You run a routine EEG, and then you do the same study using this product, and then you get two epileptologists to review it blinded, and come up with some metrics on assessing the EEG. Yeah, I mean that would be objective data to present to people who may have some questions.
Cool idea. Love it.
And then the other piece is the reimbursement issue, right? So, anything that threatens current revenue streams, whether you agree with the rules of our current system or not, but anything that threatens it will probably create resistance. And then on the other side, if you have a hospital that currently doesn't provide EEG services, but they're worried about investing in a tech, then this could potentially alleviate some of those concerns, because this would be a low cost entry, into doing those tests, and they're reimbursable. So. I think that a demonstration like you're already doing, just showing a physician very quickly that this could be applied in literally minutes, and then demonstrating how quickly the signal can be started and captured, and the size of the amplifier and all that. Any type of remote capabilities, in other words, allowing them to review a study at home, I think would be of value, right? Yeah. Medical record integration is something that everyone strives for, just because it's you want to live in one system. I'll point out now that our current EEG systems don't live in the medical record, at least not that I'm aware of. So most of them are freestanding proprietary systems. You read the EEG completely outside, then you write a report. Maybe the report is auto-generated or whatever, or you write it free text, but you then have to put it into the EMR. So that's the current system, right? So if your product was integrated, then I would consider that to be superior. I don't know that I see that it is absolutely necessary, because we're not accustomed to having an integrated EEG reading system now. Does that make sense? We wouldn't be having this conversation if I didn't think the product was very interesting and that it had a lot of potential. I think that from both a clinical care case and from a business case, kind of an iterative approach to identifying some niche areas that currently are really lacking, right? So I keep coming back to the community care hospitals and the emergency rooms. If you're trying to compare, what could be to what is now, there's essentially there's nothing now, right? So there is no standard of care. And so that's a very, in my opinion, relatively straightforward use case to make, right? So you say there's low entry cost, very easy to apply. So you target those areas first. And then as you're getting experience with that, you can be iterating on the design, maybe, working on the gel so that the cap could stay on longer, coming up with designs that allow you to modify additional electrodes in the frontal part of the face. And so then once you're doing that, you could take the next step, which is exploring expanded indications, for instance, long-term monitoring, greater than 72 hours, maybe the ambulatory market. You can envision some type of combined system where you had some video capture, right? Because that's important for an ambulatory study. But you don't try to do that all at once, right? So you just do stepwise progression. I think that's probably the best approach. You know, there's a variety of vendors out there that make the existing EEG rigs. You know, CareFusion, Nicolay, Neon Coden, Exeltech. So I think all of them, you know, who are here at this meeting, right, probably have divisions that are working on similar things. But I think that I would consider them to be the leaders in the field. Yeah. Most epileptologists, you know, are, I would say, unless they're researchers, you know, they're clinical neurophysiologists as well. So they're known leaders in EEG, right? So the same people that, you know, you're going to hear Jackie French and Bob Fischer and Larry Hirsch and Oren Davinsky. I mean, you can go on and on and on. I would consider them all to be thought leaders in terms of the EEG space as well. Well, I mean, basically it's my experience. So we just start using them, and you know, if they're easy for the technicians to use, and we're able to successfully run studies, and I consider to be the data to be of high quality, then I would consider that to be a success. You know, I think the one area where we could do better would be efficiency, right? So, you know, we're very focused on getting good EEG signal. That's requisite. That's the most important piece. You know, but sometimes the systems are kind of clunky. They require, again, they set outside of the EMR. There's no good way to generate reports quickly. We ended up having to just type our reports up or dictate them. So all that could be a lot better. But once we've invested in a system, right, it's so high cost in terms of making the commitment that, you know, the likelihood that you're going to like change systems because of some, you know, modest inefficiency is pretty low, right? So once you have a high quality system that gets good signal, you're like, this is it. I mean, you just spent a lot of money to set it up. So, I mean, that's how I judge success, but I do think there's a lot of room for improvement. Ultimately, you know, the clinical champions, the experts, are us, right? So it's the epileptologists. I would say usually, you know, the chief of the division, and you know, we kind of come together before we would make any acquisition request, and you know, go through the various vendors and maybe get some demonstrations and try to determine which one we thought, we would do that. Yeah, absolutely. I mean, not just me, but you know, everybody who's in the team. Yeah, that's how we would do it. But then once you make a decision, then a whole other cadre of people get involved, right? So you may have, you know, the business officer for your department, maybe neurology, some administrator basically, right? So a hospital administrator, usually a logistics division who's going to do the actual procurement process and establish the relationship with the vendor and actually pay them, right? And negotiate the contract. So, and those people will have questions too. So they'll, you know, sometimes they'll come back to us and say, oh, do you really need this feature? You know, it's an extra $20,000 or whatnot, right? So we don't unilaterally make a decision and then write a check and then that's it, right? It goes through this whole, a little bit of a bureaucratic process in terms of actually getting.
How long is the process, like usually? Like,
I mean, it can take months, yeah.
1 month or a few months?
No, more than that. Yeah, maybe even 6 months in terms of the whole process.
Yes.
Yeah.